Hello and welcome. This is Ben Miller with the Acheson Group, and welcome to today's joint webinar between the Acheson Group and CIC Health. Today's webinar is being recorded, so it'll be available on both of our company's websites after we're done here. So if you'd like to share it with others, it will be something you can watch online. Today we'll be talking about COVID-19 assurance testing and how you can use assurance testing, and we'll get into what that is, to reduce the risk of COVID-19 transmission in your plant, your facility, your office, whatever setting you have current risk mitigation strategies in place that you want to be able to verify how those are working and ensure that you don't have asymptomatic cases in your workforce. I'm Dr. Ben Miller, Senior Director of Scientific and Regulatory Affairs at the Acheson Group. This is a space that we at TAG have been working in for quite some time, really going back to the beginning of February. And certainly as the pandemic has evolved, so has the science, so has some of the availability and technology around testing. And we'll walk through that today, as well as trying to frame this in the context of why would you want to test? What are some of the questions you can look at answering, and how you can use some of these emerging and existing technologies to help continue to reduce the risk profile for your workforce.
Thanks, Ben. And I am not Tim Rowe, but we expect Tim Rowe, the CEO of CIC Health, to be joining shortly. My name is Adam. I worked with Ben to set up this webinar. But I can certainly stand in the meantime until he's able to join.
Thank you, Adam. So I will start off, run through the first few slides, and then pass it over to CIC, and then we'll finish up with some questions or just some thoughts on testing plans, testing design, and then we can open it up for questions so we can use those. You can use the chat box to put those forth, and Adam can read those, and we can walk through those at the end of the webinar. So again, today's webinar is being recorded. Just ask that you remain on mute and use that chat function to submit any questions that you have as we go through the presentation. So just brief background on TAG. We've been working obviously with the food safety industry for almost a decade now on food safety and regulatory issues, but since February, really been immersed and involved in helping food companies understand the risks that COVID-19 presents to its workforce, as well as develop some preventive public health programs and measures and get those implemented to reduce the risk of in-plant, in-office, in-restaurant, in-facility transmission. My background, I am an epidemiologist. I have a master's of public health and epidemiology and PhD in environmental health, with an emphasis on infectious diseases. So this is a space that I've worked in prior to joining TAG, and was epidemiologist of the Minnesota Department of Health. Adam, do you want to just speak briefly about CIC?
Yeah, absolutely. CIC Health, kind of like TAG, made a big foray into the COVID-19 world when it presented quite a big issue to our parent company, which is CIC, which stands for the Cambridge Innovation Center. We have evolved quite a bit, but CIC Health makes scaling up COVID-19 testing possible, and we really work as a logistics provider in making COVID testing affordable and accessible to organizations that need it most.
All right, thanks, Adam. So why test your employees and workforce? And really, this is one of the things that, when we work with the clients that we have today, there's often questions around testing and what testing is relevant, what technologies should I be looking for, how many people should I be testing? And so, the way that we at TAG tend to approach this problem is to really ask whoever we're working with to try to define the problem that you would be trying to answer through testing. And so, these are some of the examples of problems that you could potentially ask with a correctly designed testing plan and with the right testing technology in place. So, are the control measures that I've put in place working? Is there a risk of asymptomatic transmission currently in my plant or in my office? Do I have transmission occurring in higher risk areas of my operation? where people, let's say, can't necessarily consistently physically distance. What proportion of my workforce might be asymptomatically or pre-symptomatically infected, and are people potentially bringing infection into the workplace from the community? That's obviously an important question to think about as we see illness rates increase really almost uniformly across the US. So, certainly as we see case rates rise above the level of 25 per 100,000 on a daily average, we're seeing widespread community transmission, and therefore the risk of someone bringing infection into the workplace goes up. Assurance testing, as CIC defines this, is something that can help answer those questions. Assurance testing by definition is frequent and widespread testing of healthy people to better enable employers, schools, others to safely resume their operations. I think some of these things that when you think about testing and what some of the inherent limitations are, the test is obviously only as good or accurate as the day of the test. It is, a preventive measure or a verification measure of some of the programs that you have in place. And we're looking oftentimes to strike that balance between surveillance, detection, and cost. Really the best kind of gold star plan is to be able to test everyone every day. A lot of that technology doesn't currently exist in a way that it's scalable to market. As we talk today on this webinar, I know looks like Tim was able to join us. He'll be speaking to some of the emerging technologies that are available. And so he'll walk through that in his portion of the presentation. So from our standpoint at TAG, what we try to do is say, how do you create a meaningful testing plan, that's cost effective? It's proactive versus reactive testing when you find someone that might be symptomatic or that have an outbreak in your facility, and compare that to the cost of an outbreak where that might affect your operations, and you may find yourself having to close a portion of operations or an entire facility if things get out of control. Certainly relevant questions as we see, again, kind of case rates increase nationally here in the US. So this is a graphic. This is something that we've been working on really since the beginning of the pandemic, and we've built this up over time. And this is sort of TAG's hierarchy of controls. So when you think about building your preventive programs, the first level starts with reducing the number of people that might be in a facility. So, essential versus non-essential employees, limiting the number of people that are coming or essential to operations in a facility is really kind of that first line of protection. And from there, we build into things like structural controls, employee and visitor wellness checks, and increasing communication and training. Then we move into some of those physical preventive measures like social distancing and physical barriers, hand hygiene, the things that we're all familiar with at this point, and move up this hierarchy of controls to, ensuring that we have a clean environment, that the HVAC systems have been looked at appropriately to reduce the risk of short-ranged aerosol transmissions, and then, finally looking at PPE. So assurance testing can help verify that these controls are working, to show that you're not finding transmission within your workforce once you implement an assurance testing program. So concepts that I think the food industry are very familiar with in terms of, verification of preventive controls, that same concept can be put in place here when we think about how do you verify that all of these measures that you've been implementing for the past, many months, in fact, are performing in a way that is reducing risk. So I will turn it over to Tim to pick up here and talk a little bit about why assurance testing and go through some of the emerging technologies and different options. Tim?
We have a very similar sort of notion to Ben's about how there are a series of preventive measures that you take. We look at assurance testing as another layer in that kind of layer cake. The classic model used in kind of science talking this problem, they actually refer to it as the Swiss cheese model. And the notion is that if you took a block of Swiss cheese, I'm sure everyone in the food industry will resonate with this notion, and you slice it, you'll see holes in the Swiss cheese in various places. Any given thing you do is going to have holes. So if you're asking people to wear masks, that's great, but once in a while they take them off or they're not worn correctly. That's true of every mitigation approach you take. So the real solution is to have several layers of Swiss cheese. When you stack them up, hopefully there are no holes that pass all the way through. And so the basic notion, of course, of assurance testing is with whatever rhythm you can enable and afford, given the technologies available to you at the time and the price points of them, you can use this to check, am I seeing transmission in my community? Is that coming up? If I can go to the next slide. Today there are kind of 3 typical types of tests that are being used. Apologies if this is material that some of you are familiar with. There are PCR tests. This is often referred to as the gold standard. This is the more accurate test. There are antigen tests. They're also known as rapid tests. They only take 15 to 20 minutes versus the PCR, which has to be sent to a lab. And that may take a day or so, sometimes more, depending on your connection with the lab. And antibody tests. Antibody tests are not really a test for COVID. They're a test to see if you have had COVID in the past. And that sometimes some people think is interesting as a way to determine who might not be at as much risk. What we have to say about antibody tests is that there isn't yet a scientific consensus for how long the antibodies will keep you safe from getting COVID again. And so for the most part, nobody's relying on antibody tests as a part of their COVID screening or their assurance testing kinds of solutions. The White House famously relied on an antigen test, and it didn't work to prevent the outbreak, as we all know. One of the issues with that test is that while it's fast, it's believed to really only tell you if someone is at the height of contagiousness. So if you may have gotten the disease 5 days ago, now you are contagious, the antigen test will show you a positive. But let's say if you're on day 2 or 3 after getting the virus, after contracting it, the antigen test is likely to show you as a negative. And so the thought is that to make that one work, you'd really have to be testing just about every day. That brings us back to the PCR test, which is what most of the universities, for instance, that are using this on campuses, they're using the PCR test. It is believed to give you 2 or 3 days window after you've taken the test where you're unlikely to be in that contagiousness window. No test will tell you have COVID if you just contracted it, a few hours ago, because there's not enough spread in your body to be detectable. But they believe that the PCR test will start to pick it up somewhere around day 1, day 2, and you're not typically contagious until day 5. Now I've got a caveat that these are approximate figures. They're the figures that are used in the industry. There are some studies, but all of these timeframes are a little bit uncertain. What we can say with some certainty and some comfort is that a large fraction of the universities, this includes Harvard and MIT, have decided that the PCR test used twice a week is an effective method to prevent significant outbreaks. And in fact, we're not seeing significant outbreaks in organizations that are doing that. There are also many colleges that are using it once a week. And while there are cases and there is spread when you use it once a week, it also seems to be preventing wide outbreaks, because there isn't enough time for it to go from one person to several people to a lot of people during the course of a week. There may be enough time for it to go from one person to a few other people. So these are the tests that are available today. If we go to the next slide, there are some technologies coming that you may want to be aware of, and that open up some possibilities, particularly in the food industry. The first is pooled testing. This is using the PCR testing that you just heard about, but there is a technology where you can essentially test many people at once in a single test. The way this works, literally, you would take the same sample from, say, a group of 10 or 20 people. The sampling process, by the way, is these days, the more modern test it's really very similar to a Q-tip, and you just twirl it in your nostril. You may have heard of tests where you may have experienced one where you have that long swab that goes way to the, almost to your, tickles your brain, they say. That's not what's being used typically today. They're using these so-called anterior nares swabs. They don't hurt, they're quick. And what would happen is your employees would each run the Q-tip through their nostril and they would drop it into a common tube. This tube would hold up to 20 of those for some labs. That tube is then tested and you get a result essentially for your location. If you have more than 20 people at the location, then you have to use a couple of tubes. And that would tell you essentially there's no COVID in anyone in this group, or there's some COVID in someone in your group. It wouldn't tell you who. The reason people do this is it's much cheaper per user. So you can get the costs of the testing down substantially, and we can talk about that later. But essentially it's at least 5-fold reduction in the cost. And so some organizations are choosing to use this as a way to scan, is there any virus in the community, in my cohort? The second newer technology that's coming, which is worth considering, is so-called environmental testing. With environmental testing, what they're doing is, or you're doing actually, because you'll be doing this yourself, is swabbing surfaces. As Ben mentioned, this is not that different from some of the other kinds of testing you may already have done to ensure you have food safety and proper controls. This would be door handles, other surfaces that many people touch. You would swab the surfaces and then test that swab. And it would basically tell you, is there someone with virus who's passing through this area? It's less helpful if you're talking about a front door that all your customers might be coming through, because someone may track it in. But it works well within your employee areas. Finally, what's coming is, and actually it's just arrived really for many labs, is unobserved sample collection. So early on, you needed a sort of a medical professional to be doing this testing. The FDA has started authorizing certain tests where an individual does it for themselves. And that just reduces the cost of the kind of the overhead, if you will, of the process of testing everybody. Not all 3 of these are available today, by the way. They may be a little bit in pilots, but if you were to contact us and say, gee, we want to do this, we'd actually be able to do it. Coming soon are a couple of things. The first is a new class of rapid tests that actually have similar accuracy to PCR. There are some folks with products on the market that are rapid but inaccurate, and they're slow but accurate. We're going to be able to kind of break that compromise. And there are several companies expected in the next 2-3 months that will have solutions for that. That simply becomes a way that you could, for instance, more quickly scan everybody and send people home before they're contagious. These accurate results basically allow you to detect someone early in the spread of the virus in their body before they're spreading it to others. And you'd basically be able to identify them and send them home and keep going. And also know that your other employees do not have spread of the virus in their bodies. The second test that's coming is sort of similar, but that would be able to be done at home. So you might be able to send test kits home. You're probably familiar with test kits that people can take home today, but what that really is, it's a test you take at home, but then you mail it into a lab. What's coming is tests you can take at home that are themselves rapid. So you might be able to have employees have a kit basically at home, a setup at home. You ask them to confirm that they don't have COVID before they come into work. So those are that's kind of a high level scan of where the technology is going. And Adam, you want to go to the next slide? Are you guys able to hear me well enough now? Is it, I'm getting a nod. Okay. So Adam, do you want to speak to this slide, or do you want me to? Either way.
I can absolutely do it. I think Tim, you're certainly.
I can speak to this. That's fine.
Yeah.
So basically, what we're trying to show here in a lot of words, and you can get copies of this afterwards, I'm sure, and read it, is that doing testing involves bringing several different partners to the table. And let me just explain what those partners are. Right now, the government requires that every test that's done for an individual, what's called a diagnostic test, to know if Ben has COVID right now, that requires a doctor's order. So you have to somehow have a physician in the picture. They don't have to be on your site, but this is just the law that says, yes, we're going to test Ben. That's this clinician partner piece. You then have lab partners. The good tests, the PCR tests right now require a facility which is going to process that test. In our case, most of our tests go to the Broad Institute of MIT and Harvard, which is a nonprofit, a very well-respected lab, but you got to have a lab somewhere in there, which means you also need some sort of logistics to get the tests to the lab and be set up with the lab and so forth. And then finally, there's a software piece, which is just like you would imagine, tracking, who was tested, what were the results, send out emails with the results and so forth. You would think that these kinds of things are all kind of neatly tied together. And if this was a kind of testing like flu testing or flu vaccines that have been around for a long time, you would have a lot of companies with all these pieces put together. For COVID, this kind of came quickly, and most of the providers are actually not connected with each other. So one of the things that we did at CIC Health was to find strong providers in each of these categories and then deal with the data integrations, if you will, between them, all of the insurance issues and billing issues. And what we do is we provide a one-stop shop so that you can get all of that together and get a test. Want to go to the next slide? So just to summarize, what we're doing today, we're providing the high quality, accurate testing. We're doing it much more cheaply than what you may have heard of, the pharmacies and so forth that are charging $150 or so per test. We're able to do it. If you're doing your own collections, it's closer to $60 for today's tests. And sound is too low. That's really weird that that's happening. I could almost think I should log out, but I'm almost done. Let me finish and then I'll log out and log in again. And then with these pooled tests, we're getting down into the teens per test in terms of prices, the low teens, in fact, which is exciting. So we've got a set of supports, if you will, so that we can train you how to do this and get you set up and get it all legal. And then Adam, do you want to do the build here? So, and then in the background, what we're doing, that you cannot see as much is we're working with the next generation testing companies, little companies out of MIT and so forth that have new ways to do this that will be cheaper and faster. We put it that way. So I'm worried about the audio. Adam, why don't you just jump in and kind of deliver the rest of this?
Definitely. So this slide kind of takes a step back and provides a bigger picture of where testing falls in our struggles against this virus. So it really will be filling the gap before we get to a point where we have a widespread workforce vaccination. And going back to Ben's risk pyramid and our Swiss cheese model, risk prevention measures such as distancing, wearing masks can only do so much, and assurance adds this other higher quality layer to ensure safety and better enable a resumption of in-person activities.
Hey guys, I put on headphones. Is this clearer now?
That's much better.
I'm getting, okay. So I don't know what it was, something with my phone. You want to go to the next slide?
All right, and I think Tim, I'm picking it up from here. So
Great.
Tim, Adam, thank you. I think when we talk about sort of testing technology and things like that, as Tim mentioned, if this was something that had been around for a while, like influenza testing and things like that, there would be more of an infrastructure there. It's a turnkey solution. A lot of that is still in development, from different companies. So a portion of what needs to be thought about when thinking about testing and designing a testing plan is what's that infrastructure, from a physical, human, and capital resource standpoint. How are you going to collect the samples? Who's going to do that? Is there a supply chain for that particular platform? And that was more of an issue earlier on. I think, when we were first hearing about testing, in April, May, June timeframe, and even into the summer, some of the reagents for these PCR-based tests weren't widely available. And so we've seen that catch up, in terms of some of the PCR technology. So that's a little more available. Some of the antigen tests aren't still quite as available in the marketplace. The federal government had procured a lot of the Abbott rapid antigen tests. And so those may not be as widely available. We're going to see these emerging technologies, and with some of the pooled testing, that's going to obviously help in terms of just supply chain pressures and things like that. So as at TAG, what we say, if you're going to look at a testing plan, can you rely on that test? Is the supply chain strong behind whoever your provider is, that that they're going to have a steady supply of options, if you embark in sort of this regular testing program. The next thing, to think about is who are you going to test and how frequently, and what is testing that population tell you, and conversely, what doesn't it tell you? It's that trade-off between being able to test everybody every day, which is going to give you essentially a complete picture of everyone's health, versus testing a portion of the population at a lower frequency. I think Tim talked about, we're not seeing outbreaks on some of these college campuses that are testing with a frequency of once a week versus once every couple of days, and that's the difference between case ascertainment in terms of figuring out what's the true disease status of everyone in your population or workforce, versus making sure that you don't have a silent outbreak going on because you have asymptomatic or pre-symptomatic people coming into the facility. Again, especially as we see case rates spike, in a broad swath of the US. So just to reinforce the concept, choosing the best test, and that's really going to depend on, some of those variables that are at the bottom of this slide at the bullet. What's the accuracy, what's the cost, and what's the time to result? Most right now is that you can kind of choose two of those things. You can get an accurate, maybe relatively inexpensive test, but you're not going to get, a result within 15 minutes. Now, if you want that result within 15 minutes based on today's sort of antigen technology, you're trading off in terms of accuracy, and then you're going to want to test more frequently. So it's looking at these different variables that fit into the equation and figuring out what's the question I'm trying to answer, and what tools do I have to answer those questions, and how does that fit in terms of, again, what the physical, the human, and capital resources that I have to bring to answer that question. That concept of testing and how often is really a balance between, statistical power and cost. Again, full population testing really does allow you to assess the health status of all your employees, and really gets to that underlying purpose of full case ascertainment and outbreak protection or outbreak prevention. There are other approaches that you can take where you're testing less than everyone in that population, and you can use some statistical models to look at how many people do I need to test to achieve a certain detectability of prevalence within that population. So, we look at things like test sensitivity, the probability that the population is currently free from infection, the probability that infection might be introduced from outside the population, what's our confidence interval, and then what's the population size of the group that I want to test. And from putting those variables into some statistical models, we can come up with a meaningful sample size that might not be everyone in a facility, but a portion of people in those facilities. And then we look and say, well, how frequently do we want to test? And so, again, it might not be everyone in that particular situation if you're trying to balance statistical power and cost, but it might be, let's say 300 employees a week or something along those lines, depending on those different variables. There's other ways to think about testing as well. You can look at targeted higher risk sampling. So if you have groups that are higher risk based on activities that they're engaged in, maybe they're traveling frequently, maybe they're a group that can't physically distance on one particular line within your facility, or maybe they have to share a break facility that's just not well configured, where there is close contact happening in that kind of setting. You can think about regular testing of that subpopulation because that they're just at a higher risk profile. You can take a more complex approach and look at modeled population sampling, where you can employ some more advanced statistical models to try to estimate what the effective rate of transmission is in your particular population, and then layer in stratified random sampling approaches to give you some more uniform coverage of that group. That's another approach. Convenience sampling is another approach, and it's something that we see some of our clients do, is just having voluntary sampling programs. There may be a financial incentive for someone to participate in that group, but that's going to bring in more people to get tested more often. One of the downsides of that approach is just that, your results could be biased based on who volunteers to be tested. So as an epidemiologist, we sort of always ask the question of what's the difference between a group that chooses to get tested and a group that chooses not to be tested, and do they have different inherent risk profiles? And so, thinking through what those results might be. Tim mentioned environmental sampling. Wastewater testing is something that communities are looking at. Some congregate care type settings like colleges have looked at. And if you've got a campus that has multiple buildings on it with fairly segregated populations, that may be an option as well. Again, surface testing to understand, is there the presence of the virus in the environment? Once you've landed on what the right tool is and sort of formulated the testing approach that you want to consider, the next really important step in that process is really interpreting the results that you get back. So, based on the test that you're using, what's the risk of false negatives and false positives? Based on the sensitivity or specificity of those tests, would you need to retest? So if I'm using an antigen test and get a positive, do I need to back that up with a PCR test to have a sense that I have a true positive? And how does the prevalence of illness within your area, your community, or your population, affect the likelihood of getting an accurate positive or negative result? And there's where we look at some of the more granular epi statistics and talk about positive and negative predictive values. So these are all the variables that really need to go into designing, at least at TAG, we think, a meaningful testing program. Obviously, getting the tests taken, getting them analyzed, and getting the results back in a timely manner is a very critical component of that. And someone like CIC, as you've heard, can speak to the real world application of doing that for a number of clients. But we think that layering in and being able to ask these kind of questions is equally important in terms of understanding what results mean and what actions you take based on those results. So if I'm getting positives in a particular area, do I isolate those cases and quarantine close contacts? Do I do follow-up testing of those close contacts? Am I targeting higher risk groups? Do I want to conduct at least an initial facility-wide baseline test to get a sense of what the true rate of illness is in that population? And then how can I use that information, depending on who might test positive or who might test negative, to reinforce some of the education and preventive measures that I already have in place? So testing is a good tool for specific applications, and I think we're seeing more interest just from the industries that we're working with in bringing this tool to help solve some of these problems. But this is a good segue to get into questions. So Adam, are there any questions in the chat? Or Tim,
I'd love to add a couple quick things to that. I think that was, first of all, Ben, thank you so much. That was really terrific. I'll pose a question to the group just to begin with. As you think about the facilities that you're responsible for, a key question is, if you have a positive today, like if someone told you tomorrow that they got tested, outside the facility at home or whatever, but they've been working there for a few days and they're sick, what is the cost of that to you? So in your particular facility, are people separated enough that you can just have that person go home and keep going and it's a minor cost? Or, as is the case in some restaurants that we've talked to, they've actually shut down the restaurant for several days upon hearing about that positive. And that's partly going to be cultural. What's the culture of your company and how would you respond to this sort of thing in this crisis? Partly it's going to be staff attitudes. Some places, I think there's more anxiety than other places about COVID and what you need to do as a company to respond. I would look at those questions as you think about what kind of program makes sense. If the cost of a positive that was unexpected and where the person may have been contagious because they, kind of got fairly far down in the process before it was caught, is high, that may augur for more testing. And as I said, it does matter a lot what your particular layout is. So if you have a whole bunch of people working, kind of close to each other in interior environments, potentially with poor ventilation, you have you have a high transmission risk in your environment. If your people are working farther from each other, they're safe distancing, they've got masks, they're not kind of on top of each other and your ventilation's good, you'll have a lower transmission risk environment that you're dealing with. And so you want to assess that as well. And this is something that Ben could help you do in kind of understanding, given your particular situation, kind of what are your risks of spread if there is an outbreak.
Yeah, no, thank you, Tim. That's excellent point.
So questions? Yes, go ahead.
Yeah, anyone is welcome to put some questions in the chat. I did have a few teed up, and so I'm wondering if like Tim, you can speak to the complementary versus like substitute nature of different testing that's available. For example, PCR versus antigen.
So what we tend to do is to hear out what the situation of our customer is, right? I'll give you an example. We're working with a major league sports team that would like to have a stadium open. In this situation, they're wondering, how do I get people safely into the stadium? Their challenge is just to know if the people that are coming in are contagious in the next couple of hours. If they're not contagious as they walk in the stadium and then they leave and you're never going to see them again, actually a rapid antigen test is a viable technology to consider because it's quick and it tells me that right now these people are okay. In another situation, however, where you're going to see those same people day in, day out, we generally are advising PCR tests because otherwise you'd have to be giving this antigen test kind of continuously, and it would get very expensive and disruptive of workflow. Where what you're really trying to do is figure out, is the virus anywhere in the community at an early detection phase, and arrange for that person not to be at the facility by the point that they're contagious. So we do recommend a discussion of your environment, the health factors that you're considering, as I mentioned earlier, how close people are working, how good the ventilation is, all of those factors. And then of the tools that are available today, I think we, and frankly, Ben would be terrific at this as well, would be in a position to say, okay, this is the particular testing structure that works well for you. The other thing that we tend to do is to point to what other organizations are doing. So it's often helpful to find an organization that has been already testing for a while in a way that you're thinking about, and you can learn what their experience has been.
Excellent, thank you, Tim. Yeah, Ben, if thinking about the importance of resulting time, for example, a PCR test could come back in say 20 hours, or a result could come back in 72. As far as risk mitigation goes, can you speak a little bit to the importance of getting the quickest result possible, and then the risk of outbreak in a population if those results are beyond that 72-hour mark?
Right. Yeah, no, I think that's a great question. And it's something that, when our clients are considering testing, what are the risks and benefits of doing that? One of the challenges, obviously, the longer that there's a delay in terms of getting those results back, the greater the risk that you've created close contacts that might need to quarantine within that particular environment. So obviously shortening the time between result, or if you're going to test people, making a decision that you are going to keep those people out of the workforce until you get a result back is another option. But usually that has some significant operational impacts. And so having a sense of what the likely prevalence or rate of infection is within that population is helpful, especially as you're putting together some of these programs, because it tells you, how likely am I to find a positive based on the testing that I'm doing. I mean, ultimately, that's what we're trying to do, is to try to find people who are pre-symptomatic or asymptomatic and make sure that they're excluded from the workforce, because we want to reduce the risk of transmission, especially as, as Tim was mentioning, in environments where you might have challenges physically distancing, people are working close together for extended periods, or air handling may be an issue in those settings. So again, going back to all those preventive measures that people have been working on for so long now, this testing or this approach can have some benefit in being able to say, okay, well, it helps me understand that these preventive measures that I have are working, and it also helps me detect potential cases of illness that might be coming in, or people that are getting exposed and infected outside an office or a plant or a facility or a restaurant. But it's going to help me find those people as well when they come to work, and limit the risk that I could have an outbreak that could spread. But right, the time to result is really a key variable in kind of that risk calculus. The sooner we get a result back, the better we feel about allowing somebody to continue to work.
If I could just add to that a little bit, and Ben, thank you. I think I agree with everything you just said. What I'm going to give you is approximate numbers, because and there are a lot of studies out there, but the consensus that I've seen as a non-doctor is that typically if you get the disease, say at noon on day 0, right? You are in contact with someone and you contract it. Maybe you spent more than 15 minutes with somebody who had it, and you were too close, and so forth. You're expected to be at your height of contagiousness at day 5.1. So approximately 5 days after that. You're expected to get symptomatic at day 5.7. And this is, by the way, why they say that temperature checking is a suboptimal. It's not a bad thing to do, but it's not a perfect way to make sure that people aren't, in your facility aren't sick, because in that period where their height of contagiousness, they aren't yet showing a temperature, and that's just how the virus spreads in the body. It builds up. You've got a high volume of virus, and then you'll test positive. You're then contagious, they believe, for 2-3 days intensively, and then it falls down. And by the point, which is about 7 days after you first had symptoms, 7 days after you contracted it, and 3 days after you had symptoms, they believe that your contagiousness is way down. So there's this window that's sort of in that sort of 5 to 8 day, from when you contracted it. That's the window you're really worried about with the folks that are in your space. And so this whole discussion really is about, given the testing you do or the other measures you take or checking temperatures, how likely is it that somebody who does pick this up, maybe in their private life, maybe they go out to a bar, maybe they, pick it up from, or a child picks it up at school and a parent gets it from the child. How likely is it that in this period where you don't realize yet that they're sick, that they're passing it on to other people? In a perfect world, they've got a mask and they're social distancing, and they're not passing it on even if they're sick, right? And that tends to hold if there's also really good ventilation, so that it's not accumulating in the space where they're working and kind of eventually getting to others. Testing is one way to do that, because you may tell at day 2 or day 3, if you're testing often enough, that this person is going to be contagious and doesn't belong in your environment. The mitigation measures that Ben talked about, that's another way you can do this. Hope isn't really a good strategy, though, in the sense if people are together and you're not testing and you don't have effective mitigation strategies, you are likely to have an outbreak. And because this disease is spreading pretty extensively throughout the country, so it's a complex problem to answer, to address, because you have to think about your situation, but it is one that does have answers, and they're getting increasingly inexpensive.
Thanks, Tim. We have a question from Drayton in the chat. With flu season on the immediate horizon, how can we screen or address this without increased testing based on mimic symptoms of COVID?
Ben, you want to jump in on that one?
I can jump on that one. I think one of the things that's will be interesting to see is, what sort of flu season we truly end up having. When we look at the influenza season in the Southern Hemisphere, they went through COVID and what would have been their typical flu season this summer, based in the Northern Hemisphere. So the months of, June, July, August, what we saw in the Southern Hemisphere is that in some ways, because of the COVID mitigation measures that have been put in place, that there was a very low level of influenza occurring in those countries. It may be reasonable to expect the same things here, but I think, you ask an excellent question because the symptoms are, essentially identical between COVID and influenza. And, I think without testing symptomatic people, we're not going to have a clear sense of, which is which. So, when somebody is symptomatic, the recommendation would still be to have them go to their healthcare provider, seek a test. If that healthcare provider, especially now that we're entering influenza season, is going to order testing, that they're ordering a COVID test, they might be ordering a strep test, they might be ordering an influenza test to really try to make a differential diagnosis based on the symptoms that they're seeing. So, the testing we're talking about here is largely of asymptomatic people, and has the benefit again, of being able to define and classify what the true or sort of estimated rate of infection within your population is. So that can help, if you're doing some of this assurance testing, you can compare the rate of infection in your workforce to what it would be in the surrounding area. And interestingly, I think what we're seeing in terms of some of the data coming out of colleges nationally is that the infection rate in colleges, especially the ones that are doing more of this kind of testing, in those populations is actually quite a bit lower than it is in the surrounding community. So, that's to say that, the testing itself isn't protective, but it gives you information that allows you to make informed decisions and sort of break the cycle of transmission within a defined population. Tim, you probably have some thoughts there.
Yeah, no, you said that very well. I think about it this way. We know well the people at a lot of the local universities that are testing, right? And we talk to them about the cases they have. They're doing the assurance testing. They figure out that, Steve, a freshman, has COVID. They're testing everybody, right? They find that only Steve has it. They quarantine Steve, like, seriously, right? Not just telling him, avoid others. And Steve's the only person who gets it in that population. Now, next door, there might be a public school that isn't testing. Let's say it's open, but it isn't testing yet. And Steve's younger brother, Jack, has it. Well, Jack is hanging out with his friends. And, pretty quickly 5 kids have it. And then they go home and they're with their families, and pretty quickly 25 people have it. This is what happened with the Biogen outbreak, where they had that buffet, way back in February, and a couple people had it. And then eventually, I think the math was that like hundreds of thousands of people got it as a result of that one event. So it really is about interrupting that cycle. That's what you're trying to do. But you can do it multiple ways. You can test, which is great, or you can have really good controls that keep everybody apart from each other, keep those masks on, the distancing. It really depends on what's going on in your facility and the way people are interacting. But if they're interacting close, and if they're, we're finding that even in the hospital break rooms, people are going in and they're going to these tiny little break rooms, and they're taking their masks off to have their lunch when they're with their colleagues. That's where these outbreaks are taking place. And so if your employees are doing that, game's over.
Yeah, and that's certainly consistent, with, I think, many outbreaks that we've seen, in the food industry have really been driven by, some of those common areas, break rooms, lunch rooms, things like that. It wasn't necessarily what was happening on the plant floor, but those were the spaces where transmission ended up occurring. I think one of the important things to consider, and I'm going to go back a few slides here, just to talk about this slide in terms of the testing timeline, is that, we're expecting some level of, commercially available vaccine probably this late spring, early summer, if sort of what we're hearing holds in terms of, widespread availability. The risk prevention measures that we've put in place in, all the different industry segments, across this country are important, and obviously reducing the risk of transmission. And we will obviously move towards relying on widespread vaccination to, return to something that looks more like 2019 normal, sort of the old normal, if you will. Although if we ever quite go back there, we'll see. But as we head, especially into the winter months in the Northern Hemisphere, I think that we're going to see increased interest in, how testing can help quantify the level of infection in a particular population, if that's within an office setting or, a school, a college, elementary school, whatever. As this testing technology becomes more available and as cost comes down, thinking about how that tool helps bridge, from where we are today to more widespread vaccination. I think the time frame too for population-wide immunity is maybe going to be longer than people might think. We look at vaccination, we know that there's a certain amount of hesitancy around initial vaccination, and if we're looking at vaccine efficacy too, right now the threshold for approval is at least 50% effective. So, if you have 50% of the population that's vaccinated and that vaccine is 50% effective, you really only have kind of a 25% protective effect. So this is going to be iterative. This is going to be something that goes on, I think is going to be challenging, certainly as we head into the winter months here in the US. I think we'll see some letting up and a reduction of cases as we head into spring and summer, certainly. But even as we look forward into mid to late next year, some of these things that we're doing today, and I think, testing of your workforce and vaccination of your workforce, I think those things are going to continue to happen in concert as we, want to reduce the chance that we're having outbreaks within, any time that you're bringing people close together from a physical standpoint. That's kind of my parting thought. Tim, I can turn it over to you, or I guess we have another question. Sorry.
Oh, let's go for the question.
A question from Joan. What are cost differences between pooled testing versus environmental testing versus unobserved sampling or testing?
Great, Joan. So the environmental testing is driven entirely differently, and it's a question of how many swabs are kind of needed to keep your environment safe. But it's going to be on the order of, I think it's on the order of $600 a time you do it. And so you could say, I kind of scan my environment, twice a week. That's $1,200 a week. With pooled testing, our current pricing looks to be around $242, I believe, for 20 tests. It's a pool with 20 swabs. If you use fewer swabs, like you don't have that many people, it's still $242. So, but if you use it efficiently, it works out to be $12 per test. Compare that with, our individual tests, if you come into our testing site, are $80 right now. But if you contract with us and you're doing the sample collection on your site, you're kind of handling the collection, it's $60 per test. So getting down to $12 is a big deal, and we're really excited by it. The unobserved versus observed sample testing is really about the kind of the cost of collection. And the unobserved, that's available now. And what that means is that instead of hiring a clinician to come to your site, which would have been an additional cost, you can do it directly. Does that answer your question, Joan? Thank you. I see a yes. I think we're at time, but are there any last questions anybody has?
Yeah, there's one more from Mark about the risk factors. So, speaking of air and air within a facility being a risk factor, what air handling factors impact the sampling plan, and how can any facilities mitigate air as a potential risk factor?
So I'll just say briefly that this is an area that there's a lot of attention, and it's not there's not perfect clarity. For instance, the airlines have believed for a while that they are filtering the air and cycling it very quickly, and that the airplanes are safe. But there have been some recent studies that say that they haven't universally been safe. That there have been outbreaks on planes. I think the basic message that we're seeing, and I'd like to hear what Ben is hearing, is that you need to have a high level of air changes, and Ben could tell you exactly what it is, so that you don't have, if you've got a sick person there, you don't have over a period of say 24 hours or 12 hours of a shift, have that levels of ambient virus in the air building up. Ben, I probably should have given this one to you from the beginning, but over to you.
No, it's good to preface. When we're trying to quantify risk and looking at, spaces that may be problematic, right? The air exchange rate, the number of air exchanges per hour, the amount of cubic feet per minute that's available to a person. ASHRAE, which is an organization here in the US that sets standards for buildings, publishes the number, like cubic feet per minute per person, depending on particular settings. And that can range from anywhere from 5 cubic feet per minute, upwards of 25 cubic feet per minute, depending on, if it's a conference room or a theater versus a gym. Those numbers don't necessarily take into account, the risk of transmission from a virus like COVID-19. And so, when we're working with clients in this space, we'll often look at, what is that, the amount of outside air that's coming into that space versus the amount of makeup air. What kind of filtration do you have? I'm sure you've heard of kind of the MERV level of filtration. So, are you at a level 13 MERV filter or higher? Some research has shown that really filters out a lot of the small particles that can move through ventilation systems. There are other environmental mitigation strategies like UV light treatment, HEPA filtration. All of those things are things that we can look at to reduce risk, especially in spaces that might not have as much ventilation as would be ideal. There's the issue of outside ventilation. That can be a challenge in a food facility. Obviously, having doors or windows open isn't usually typically an option. So it's a great question. It's kind of multifactorial. If you end up in a situation where you probably have a lower air exchange rate than would be ideal, thinking about targeted testing of people who work in those areas is one potential solution, because it allows you to assess, is there increased risk, in that group? And, if you had somebody that was pre-symptomatic or asymptomatic working there, it's more likely that they could, spread the infection. We certainly saw that earlier on in working with a number of companies, on lines where physical distancing wasn't able to be practiced, and, you had asymptomatic workers coming in and spreading the virus, and then, having symptomatic people show up in the workforce. So we do know that kind of scenario can lead to spread. So sorry, that was a long answer, but worth answering, I think.
Excellent. So with that, we are at time. Ben, thank you for presenting, and Tim, thank you for presenting as well. And for folks who mentioned that they would like follow-up information, we'll follow up today with some further materials and a recorded version of this webinar. But with that, I think we can end this presentation, and I hope everyone enjoys the rest of their day.
Yeah. Thanks, Adam. Thanks, Tim. Thanks, everyone.
Thank you.
All right.
All right. Bye-bye.